Chapter 16, disorders in immunity. Okay. You're talking about the immune response, the B cells, the T cells, how they respond with history and everything else. So immunopathology isn't something goes wrong. The study of the disease state, either underactivity or overactivity of the immune response. Allergies. Allergies are hypersensitivity. It's an exaggerated expression of the immune response to an allergen, to an antigen. Okay? That's what an allergy is. You get a hyper response to it. Autoimmunity is a normal response to self-antigens. Tissues that have antigens that should be recognized as self-tissue. Immunodeficiency is loss of immunity or decrease in immune function. And cancer, which has a cause and effect of immune dysfunction, which allows normal cells to grow at a rapid, accelerated rate. Right? These are your system disorders. You have type 1, which is immediate response, hay fever, anaphylaxis, just immediate response to an allergen. You have type 2, which is an antibody-mediated response, where you form B cells and T cells, and they respond to the antigen. Okay. Blood type incompatibilities, like giving someone a transfusion with the wrong blood type. Okay. Type 3 is an immune complex, like rheumatoid or serum sickness, rheumatoid arthritis or serum sickness. Type 4 would be cell-mediated cytotoxic. Okay. Contact dermatitis, graft rejections, when the immune system rejects a graft or a transplant is put in the body. Okay. Underreactions, those are overreactions. All those are reactions where the immune system is overstimulated. Underreactions are loss of function. Okay. Lack of T cell surveillance leads to cancer cell survival. The T cells don't destroy what they should destroy. Or loss of T cells, B cells, or both compromise the immune system. Okay. They both work in conjunction with each other. All right. So these here, we just talked about class 1 is an immediate allergies. They're IgE mediated, involves mast cells, basophils, and allergic mediators. And type 2 was antibiotic mediated incompatibilities, IgG, IgM antibodies, act upon cells with complement and cause cell lysis, including some of your autoimmune disease, like lupus. Right. Immune complex diseases is type 3. Where the antibody-mediated inflammation, which is your circulating IgG complexes, deposit in the basement membrane of the target organs. Okay? Those include also some autoimmune diseases. It's when they go into the basement membrane of the epithelial or your target organ and release response there, causing destruction. You get rheumatoid arthritis, serum sickness, rheumatic fever if it lodges on the heart. We'll give you rheumatic fever. Type 4, T cell mediated hypersensitivities. Delayed hypersensitivity is cytotoxic reactions in tissues. Graft rejection, some type of autoimmune diseases also. Okay. So type 1, allergic reactions, we're going to talk about here. Type 1 allergies share a similar physiological mechanism, are immediate onset and associated with exposure to a specific antigen. Okay. There's 2 levels of severity. There's an atopy and anaphylaxis. Atopy is a chronic local allergy, like hay fever or asthma. Okay. Anaphylaxis is a systemic reaction. Okay, often reaction involves airway obstruction and circulatory collapse. These can be life-threatening within minutes. Okay. A lot of people with severe reactions to bee stings, to peanuts, to other things that found commonly carry an epinephrine pen. Epinephrine contradicts or stops the reactions of anaphylaxis. Factors that affect this allergy onset, they're generalized predisposed to allergies, is familial, okay? Not to specific allergies, okay? Passed down generations. Allergy can be affected by age, T cells, B cells become older, okay? Infection, or the geographic area where you're at. Atopic allergies may be lifelong or maybe outgrown. Okay, they also can develop later in life. You can develop allergies to certain things. Okay, allergens have immunogenic characteristics. Their typical enter either through the epithelial ports to the skin, respiratory, you breathe them in, gastrointestinal, you eat it, or through the skin. Okay. Organs of allergic expression may or may not be the same as the portal of entropy. So it all depends how it gets in there. Common allergens, things that cause an allergic reaction, hay fever response, things like that. Pollen, dust, mold or spores, dander, animal hair, insect parts, formalin, or aerosols are all common allergens. Those are inhalants. Those are things that come in through the respiratory system. Ingestions, which you bring when you eat food, okay, like milk, peanuts, wheat, shellfish, soybeans, nuts, eggs, fruits, things that people are commonly allergic to, or food additives. Right? Oral drugs like aspirin and penicillin are common allergies. Injectants, things that you inject in the body, like a bee or a wasp sting. Okay? Insect bites, certain drugs are given IV. Vaccines, serum, enzymes, or hormones can all be injected. Allergens that are contact, okay, topical drugs you place on your skin, cosmetics, okay, that would include certain types of soaps people use, stuff you wash your clothes in, okay, those have contact allergens. Heavy metals, detergent, oh, there you go, detergents. These are about different soaps. Formalin also, rubber, solvent, dyes. A lot of people are allergic to latex. Okay, that's a contact allergen. Okay. The primary contact and sensitization. They have to have a sensitizing dose. The dose has to be large enough to provide an allergic reaction to occur. So provided on the first contact with the allergen, the first time you come into contact with allergen, you will not get a response because you will build up your memory to it. You'll build up your B cells, will recognize your T cells, and it takes a while. Generally, there's no signs or symptoms if it's mild enough. Okay? It's the second time. So you have to have a sensitizing dose first to develop the B cells, the T cells, the B cells that form memory, they're going to react with it. So the antigen is processed by dendritic cells, okay, that trap the allergen. They activate the helper T cells in the lymph nodes. You get the interaction between the helper T cells and the B cells. Those produce plasma cells. This is your IgE immune. Those are your antibodies attached to mast cells and basophils. This primes the immune system for the next encounter. Okay, so your allergic reaction is only after the second time. You have to have a sensitizing dose first. Okay, so here's your sensitizing dose, allergens, enter through the mucous membrane and are picked up by the dendritic cells. Remember all those branches? They trap all the allergens. They engulf it, they process it, change it, and it expresses these receptors on the outside of the dendritic cell. This is now recognized by a B cell, and it forms a complex and binds. Okay? B cells then go on to divide to form specific antibodies. Okay, those are YG antibodies found in the plasma. These guys here are your memory. They're going to cause an allergic response the next time you get exposed to it. Okay, so if you get exposed to it, the IgE binds to the fragments and it marks these as foreign, and the granules with inflammatory mediators get released, and you get your inflammation, you get your allergic response. Okay, so after you have the exposure to it, then you get provocation. You have to have a provocative dose. So subsequent exposure with the same allergen precipitates the first allergic symptoms. Let you get your response. So the allergen binds to the IgE mast cell complex, that's your antibody, and triggers degranulation. Remember, degranulation releases mediators with physiological effects like vasodilation, bronchoconstriction. It causes a chemical gradient to occur where it attracts other T cells area to help destroy and destroy the allergen. So subsequent exposure. Okay, we get the antibodies that attach to it. So the allergen attaches to IgE and triggers degranulation. So here's your allergen, dots you attach to your antibody in the B cells, and you get degranulation. This stimulates the B cell system of distributed mediators in the bloodstream, results in itchy eyes, hives, runny nose, all the good stuff associated with allergies. Release of histamine, like I said, vasoconstriction, and all that. So mast cells and basophils, what do? They have a ubiquitous location in tissues. So mast cells are located in the connective tissue of virtually all the organs. Okay, those are your mast cells. They have a high concentration in the lungs, the skin, the GI tract, and genital tract. Basophils circulate in the blood, okay, and migrate into tissues. So mast cells are already there, basophils circulate and migrate into it. Each cell can bind about 10,000 to 40,000 antibodies, IgE antibodies, that are circulating in the plasma. Okay, the cytoplasmic granules contain physiological active cytokines, histamine, and the like. So they degranulate, they release the contents of the granules when stimulated by the allergen. That's what causes the allergic response. Okay. And we talked about this last time, how this is a combination of everything. Allergen gets trapped by the dendritic cells, triggers the B cells, and it forms your antibodies. Antibodies, once they're formed, wait for the second exposure to the allergen. Okay, they bind it, and then they release histamine and their other cytokines into the circulation. Okay, and that results in the symptoms that are very important. Like the eye becomes red and itchy, get highs on the skin, and runny noses, and so on. Okay, so type 1 allergic reaction produces symptoms upon the second exposure to an allergen. True or false?
True.
Okay, very good. That is true. It's a second exposure to the allergen. The first one usually does not provide any symptoms. It could be severe enough where it does, but usually it does not. Okay? You have to get exposed when you first become sensitized to it, and then your second exposure produces the allergic response. Perfect. So cytokines start working on allergic symptoms. So chemical mediators are released by the mast cells and basophils. They act together or separately, and they account for the allergic symptoms. So what's released is histamine, serotonin, leukotriene, platelet activating factor, prostaglandins, and bradykinin. Okay? These target certain organs, like your skin, your respiratory tract, your lungs, GI tract, and the conjunctiva of the eye. Okay? The response of these mediators, okay, gives you rashes, itching, redness, rhinitis, sneezing, diarrhea, shedding tears. All those effects. Okay, the systemic targets like smooth muscle, okay, mucous glands, and nervous tissues. So response includes vascular dilation, causes a smooth muscle around your arteries to relax, open up, your vessels dilate, okay, vasodilation and constriction, okay, depending on the allergen. Some will cause constriction, some cause vasodilation, resulting in a change in blood pressure and a change in respiration, the respiration rate. So histamine. Histamine is the most profuse and fastest acting. Okay, that's the most quickest one. Stimulator of smooth muscle, glands, and eosinophils. Okay, the response to chemical depends on the muscle location, but it constricts smooth muscles around your bronchi, around your intestines, and relaxes vascular smooth muscles in the bloodstream. So it causes vasodilation in the bloodstream, but it causes a constriction of the small bronchi, resulting in increased pressure in the lungs and in the intestines. Okay. Serotonin works in a complement to those of histamine. The leukotrienes are slow reacting substances of anaphylaxis. Okay. They produce prolonged bronchospasm where the lungs constrict and don't loosen back up. Vascular permeability and mucus secretion of the asthmatic individual. The prostaglandins, powerful inflammatory agents, regulate smooth muscle contraction. That's how aspirin, Tylenol, they affect the prostaglandins, okay? And they shut down the inflammatory response they use for pain medications. Bradykinin causes prolonged contraction of the bronchioles, okay? Dilation of peripheral arterioles, increased capillary permeability, and increase in mucus secretion. Right? So here's your B cell getting on the degranulation. Okay, the prostaglandins get released. Prostaglandins called dilated blood vessels. They constrict your bronchioles, and they affect the nerve cells, causing headaches. Degranulation, the histamine, serotonin, bradykinin, they all affect the smooth muscle. Again, get blood vessel dilation. You get your wheals, flaring, and itching reaction, dermatitis on your skin. In the bronchioles of the lung, they constrict the lungs. Okay, get wheezing, difficulty breathing, coughing, increased peristalsis of the intestine, you get diarrhea, vomiting. The secretory glands cause more runny noses, eyes watering, things like that. Okay, so you have prostaglandins, you have histamine, serotonin, bradykinin, and then the leukotrienes. Those are all granularly released by the mast cells when they're activated from the antibody complex binding to the antigen. The leukotrienes cause airway obstruction by causing a mucus buildup, and you get that as you cough things up. Constriction of the bronchioles again, okay? And that's your typical asthmatic response. Diseases attributed to type 1 allergies, okay? Atopic diseases, okay? Hay fever, rhinitis, seasonal allergies. Antigen may be inhaled to the lungs, topical, applied skin, or ingested. We talk about all the different types of ways of getting into the body. Allergic asthma, you get bronchial constriction. You get the bronchioles of your lungs constricting down, making it more difficult to breathe. That's why they carry inhalers with them. Atopic dermatitis, eczema. Eczema causes the dermatitis on the skin surface. Food allergies. The intestinal pore can affect skin and the respiratory tract. With food allergy, you can get vomiting, diarrhea, abdominal pain. Eczema, hives, rhinitis, asthma. Occasionally anaphylaxis. Anaphylaxis is rare, but it does occur as a reaction. And that shuts down your circulatory system and the respiratory system. Drug allergies are a side effect of treatment. Any tissue can be affected in a drug allergy. Reactions can be from mild, like a skin rash, to fatal anaphylaxis. Okay. Again, skin rashes can occur from any kind of drug allergies. These are type 1 allergies. That's dermatitis, like eczema. Anaphylaxis. Anaphylaxis is one you're worried about because that's a life-threatening reaction. That one has to have response immediately or the patient's going to die because they're not going to be able to breathe. Anaphylaxis is a reaction of animals injected with a foreign protein. Reinoculation showed acute symptoms like itching, sneezing, difficulty breathing, prostration, convulsion, and death. There's 2 types in humans of anaphylaxis. There's cutaneous anaphylaxis and systemic anaphylaxis. Cutaneous anaphylaxis is a wheal or flare inflammatory reaction to the local injection of allergen. Okay, the reactions is constant to the cutaneous tissue, to the epithelial tissue. Okay, systemic anaphylaxis is what's called anaphylactic shock. Okay, that's sudden respiratory and circulatory collapse. And that can be fatal in just a few minutes. And the allergen route can vary. Bee stings, patients are to bees, that's injection. Antibiotics, drugs can be given. Common allergies to penicillin. It can cause this. Serum injections. Okay, could come by digestive tract, allergy to peanuts. Okay. So when you diagnose allergies, we do little allergy tests. So it's important to make sure you put an allergies or an infection on there. You do skin testing. You put in different antigens, just small amounts of each one, and then you check the reaction on the skin. You have a little array, and it's arranged in place like that. And different allergens are in different wells. And you have a key that shows you what they're allergic to, but the responses, like here you can see this allergy reaction to a spider bite. Okay. And this is your environmental allergens, and then airborne particles. Okay, environmental allergens would be like glue, horse dander, cat dander, dog dander, silk, upholstery, wool, things like that. Airborne particles could be from like an ant, an aphid, bee, housefly, different types of animals. Okay, different types of molds or spores. And you type the type of reaction that they have. If you see the X here, you know there's no reaction. Okay, if you see multiple plus signs, like upholstery dust right here, you have an extreme degree of person's allergies. Okay. In fact, my wife just had all her testing done and she's allergic to dogs. So we used to have Great Danes and St. Bernards, which are phenomenal for hairs and dander and all that fun stuff. So the new dog we got is a giant schnauzer. He is a hypoallergenic dog. He does not have fur. He has hair, just like humans. So he doesn't shed, and there's no allergic reaction. The dog can sleep in the bed, can roll around the house, lay on the couches, and there's no reaction. Which means all that fun drug testing. So what you do is you avoid your allergen. That's what you need to do. Avoidance of allergen causes no reaction. Okay. And so it's all good. Okay. We use drugs that block the actions of lymphocytes. Okay. Mast cells are chemical mediators, they're antihistamines. Okay. They stop the effects of histamine reaction once the reaction starts. Desensitization or hyposensitization therapy. You get injections of allergy, those are allergy shots. Injections of allergy stimulates high levels of allergy IgG to prevent the IgE allergic binding in the mast cells. So you give them doses every 2 to 3 times a week, and it keeps the levels high enough so the allergen bonds to the IgG that's been injected. Okay. And then when it's coming, when you get exposed to it, then the IgG is not triggered because the IgG has used it all up, and then we got to be just because sensitive to it. It just becomes just like when you, that's where I'm looking for. Like you're sensitive to something, and with you become tolerant to it. It becomes larger doses. Like let's say heroin addicts, they need a greater dose to have kind of the same effect. You get not sensitive to it, but you get immune to it. You have to have a higher dose to keep it coming. This is the same way. Eventually, the body gets used to it, and you don't get the response anymore. So it binds to this IgG, which does not produce this response. So the IgEs can't bind to it. And then it causes a decrease in sensitivity to the allergen. And this is the slide we showed before with it. The allergen binds to it. The IgG binds to your allergen. So the IgG can't. So there's no allergen to bind with the mast cell because the IgG molecules bind with the mast cells and produce it. So there's no binding with the IgG, and then no degranulations, no allergic symptoms. By injecting IgG antibodies. That's your allergy shots. Okay. So which of the following are considered major chemical mediators of type 1 allergic reactions? Either prostaglandins, histamines, leukotrienes.
I would say all of the above.
I would say all of the above too. Prostaglandins and histamines, leukotrienes all exhibit reactions to type 1 allergic reactions. So definitely be all of the above. Perfect. All right, type 2. Type 2 allergic reactions are hypersensitivities. These are reactions that lyse foreign cells, actually put holes in foreign cells or the allergen and cause it to be destroyed. These involve antibodies, complement-mediated lysis of foreign cells. These are your transfusion reactions, your blood types, AB, your A, your B, your AB, and your O blood types. And your Rh factor is your hemolytic, causes hemolytic disease of the newborn. Because the Rh factor in the mother and the baby can be different. And that's when you run into trouble. That's when you have to use the Rogaine shots to prevent this hemolytic anemia of the newborn. Okay, so you have 4 distinct blood groups. You have A, you have B, you have O, and you have AB. Okay, those are the proteins that are on the outside of the red blood cell. Okay, well, there's your 4 types right there, A, B, or O. It's named for the dominant antigen. So a person that is blood type A has A antigens on the red blood cell. So if this is your red blood cell, you have A antigens coming off of here. If you had B antigens, you'd be type B. If you had both, you'd be AB. If you had neither, okay, you would be O.
Professor, what did you say? You said something about the baby, how like if the mom's blood is pretty much counteracts the baby's blood, like the baby can like, or the mom can kill the baby because their blood is not mixing pretty much.
Right. That only occurs if the mother is Rh negative and the baby is Rh positive. Okay. If the mother's Rh negative, that means there's no Rh factor. So she has no receptors on the bloods for Rh. Now, if the baby is Rh positive, then the baby has a positive receptor. The mother's going to recognize that as foreign and destroy the baby's blood. Now, that only occurs if the mother becomes sensitized to it. So the first child is not a problem because the blood doesn't mix. Okay? During birth, the blood mixes. Okay, because there's bleeding at birth and the blood can get mixed. The mother can have Rh. Once that happens, the mother develops the antibodies to Rh. So the next child, with her blood going through the placenta, has the antigen to destroy the Rh factor. If the second baby's Rh positive, the mother can start to destroy that baby's red blood cells. Now, mothers are, if the case is that the mother is Rh negative, baby Rh positive, the mother's given an injection of Rogan. Rogan is a form of the Rh factor. So the mother's blood finds that, doesn't respond to it because that basically binds it up, just like the other allergy shots did. It binds up the factors so the mother doesn't produce the antibodies against the Rh factor. It's already destroyed by what we've injected. Remember, we inject someone with antibodies, it doesn't cause memory.
Yes.
Okay, and that's how it works.
Wow, that's I like was writing everything down as you're talking because I was like, I find that it's like very interesting.
It is, it's real interesting. Because we didn't know about it for a long time. And you couldn't figure out what's going on. And it's hemolytic anemia. That's what a lot of children died of. Newborns died of.
Wow, but luckily we do have that Rogan injection.
Yes, and I get Rogan shots. And like I said, it doesn't occur with the first one, but they get the Rogan shots to prevent the reaction once the bloods are mixed. So that way the mother's prevented from developing the antibodies against the Rh factor.
It's kind of like how like in the allergies situation where you don't get that reaction until the second exposure.
Right, exactly. It's exactly the same thing.
Okay, thank you.
Yeah, oh, you're welcome, no problem. Like I said, this is prevented from developing. We'll go over a little bit more of it too here. So the type O lacks A and B antigens, and the tissues other than red blood cells also carry A and B antigens also in there. Now, so if your blood type is A, you have the genotypes A and AO. Okay, the antigen is A. Now in the plasma, what's really interesting too, is you have anti-B. Okay, so if you've got a person with blood type A, not only do you have the red blood cells with A antigen, you have antibodies against the B antigen. Okay, that was developed inside the person. So if you get a B blood, it will destroy it because of those antigens. So you have anti-B antibodies. Okay, so a type B patient has anti-A. If you're A and B, okay, you don't have any either anti-A or anti-B. But if you're blood type O, okay, you have anti-A and anti-B in your system. So you destroy any blood cell with an A or a B on it. Now, the most common types are type A and type O. The least common type is AB. So serum contains these preformed antibodies that react with the blood of another anti-type agglutination, possibly transfusion concerns, which is transfusion concerns. Type A contains antibodies that kill the B antigen because it's foreign. It's not in your system. It's foreign to you. Type B contains antibodies that kill the type A antigen. If you're type O, you don't have any A or B antigens, so you have antibodies that react against both A and B. If you're type AB, okay, it contains no antibodies because you got A and B on there, so neither one can be, you can't have antibodies against it because those are both your own cells. Okay. So there's your type A. As your A antigen bond to the surface. This is type B. This is type AB blood. And this is type O. Okay. There's no markers on that one. So if you get, what happens is, if you give someone okay, this is a type A patient. So what happens is if you give them the anti-serum for A, what they do is the antibodies bind together and they form those masses. So it's called agglutination. And it clogs up the red blood cells. And the circulation doesn't work because it can't get past the clots. You see agglutination for type A, agglutination for type B. Type AB, you have A and B on the receptors. So when you do the blood test, this is how you do the blood test. So the anti-B reacts with B, anti reacts with A. So both wells cloud up. And with it's type O, you get neither acting up. So they used to do this in the labs before COVID shut everything down. You couldn't take people's blood anymore. But you put a drop of blood on the slide, you put on anti-A and see if it agglutinates. Put an anti-B, you put in a drop of blood, put in an anti-B, see if it agglutinates. So if the A agglutinates, the person's type A. If the B agglutinates, person's type B. If they both agglutinate, both wells, it's like AB. If you get no agglutination, it's type O. That's how you turn blood types. Very simple experiment to do. Okay, so if we had a type A donor to a type B recipient, so your patient's type B and you give them type A blood. Remember, type A blood, okay, has anti-B antibodies. So the antibodies bind with the B receptors, forming agglutination, okay, and the loss of hemoglobin, loss of it causes fatality. It agglutinates the blood. Okay, here's your hemolytic disease of the newborn. This is your argument we talked about. So when a mother is Rh negative and her unborn child is Rh positive. Now, if they're both Rh positive, they're both Rh negative, or if the mom's Rh positive, it makes no difference. The only combination that can be fatal, causes hemolytic anemia, is if the mother is Rh negative and the baby is Rh positive. Because remember, once the blood mixes, the mother's blood doesn't have Rh factor in it. So it's going to find it as foreign. So it's going to recognize this blood as foreign and produce antibodies to destroy it. So fetal red blood cells can leak into the mother's circulation during childbirth. During a normal pregnancy, okay, the bloods don't mix. You have the placental barrier, it can exchange gases there, but you're not transferring blood of the fetus to the blood of the mother and vice versa. You have an umbilical barrier there. So during childbirth, you can get mixing of the blood systems. This sensitizes a mother's immune system, like we said. So the first Rh positive child is usually not affected. A second one with Fonter can be fetal hemolytic anemia to the fetus. So the hemolytic disease in a second pregnancy, the maternal anti-Rh antibodies can bind to the fetal's red blood cells and produce hemolysis. It binds up the red blood cells and destroys them. So we use a passive immunization of the mother antibodies against threat, prevent it. That's your RhoGAM injections. Again, that causes the Rh positive portion of the fetal blood that got in the mother's circulation to be bound and destroyed before the immune system can recognize it as formed. So the mother doesn't make antibodies against it for the second child. Make sense?
Yes.
All right. But yeah, it's real interesting how it works. So if the mother's Rh negative, the baby's Rh positive, that's when you're in trouble. Okay. And the first product is no problem. It's usually the second child where you get the Rh positive factor. This is your anti-Rh antibodies, which is your RhoGAM shot. Okay. And that prevents the mother's immune system from responding to the baby's Rh positive antigen. Okay. Type 3, hypersensitivity, is reaction of soluble antigen with antibody and the deposition of resulting complexes in the basement membrane of epithelial tissue. Okay, so the complex where the antibodies bind to the B cells, okay, bind into the basement membranes of your epithelial tissue. So it's just below the layer of the skin. Okay, this immune complex becomes trapped in the tissues and incites a damage inflammatory response. Now, this can occur in the skin in the basement membrane, or it can occur in your organs, like in your heart, in the basement membrane of the tissue, okay, or in your kidneys or your lungs. It can occur in different organs also and cause damage in those areas. So Arthus reaction is a localized dermal injury due to inflamed blood vessels from this lodging in the basement membrane. Serum sickness is systemic injury initiated by the antigen antibody complex that circulate in the blood. Okay, so the pathogenesis of this complex disease, these are your immune complexes. You can see your antibodies, your Y-shaped antibodies, you're binding to the antigens, okay, and they lodge in the basement membrane, okay, of epithelial tissue. Okay, They release their factors, they trigger a damage inflammatory response. They release all those inflammatory mediators into the tissue. Okay. Now it can bind the epithelial tissue of, like we said, the skin, but it can also do the blood vessels, the kidneys, other sites of the heart. Okay. So these neutrophils migrate to the sites of the antibody antigen complex and release enzymes and chemokines that's really damage the target organs. Okay. Like I said, it can be in the skin, where it does basic membrane of the epithelium of the skin, or it could be in the blood vessels, the heart, the lungs. It can be in the joints, rheumatoid arthritis, okay, kidneys, etc. Okay, there's different phases when you get this immune complex disease. The antibody here combines with excess soluble antigen, forming large quantities of the antibody antigen complex. So the circulating immune complex becomes lodged in the basement membranes of the epithelial, like I said, in blood vessels, kidney, skin, heart, joints. Complement factor triggers release of histamine and other inflammatory mediators. Okay? So you get inflammation in, like with rheumatoid arthritis, inflammation in the joints from these factors releasing histamine and the other inflammatory mediators. Neutrophils migrate to the site of this complex and release their enzymes and chemokines. That's really damage the target tissue and organs. That's a damaging effect of this reaction. All right, immunopathology involving T cells. This is type 4 hypersensitivity. This is delayed hypersensitivity as symptoms arise on 1 to several days following the second contact with an antigen. This is your T cells. Remember, T cells have to be activated on the second response, because you get the T cells being activated, the B cells forming memory cells, and the antibodies. So in general, type 4 diseases result when T cells respond to different antigens played on self tissues or transplanted foreign cells, like a delayed allergic reaction to infectious agents, contact dermatitis, or rejection of a transplant or a graft onto the body. Okay. When you want to test for these, if you're going to be able to accept this graft, like I said, we have the array set up. We test in different things, different allergens, and what you can tolerate. So here's your contact dermatitis. This is your chemical antigens. This is showing going through the surface of the skin, the epithelium. This is your dendritic cell that captures the antigens, breaks them up, and displays the antigens for the body to see if it recognizes it. The helper T cell binds to it. Okay, and it causes the B cells to become macrophages. Okay, and it forms the cytotoxic T cells and the memory B cells to form antibodies to it. And the inflammatory, it lodges in the basement membrane here, which supports underneath the epithelial layer, and it causes inflammatory fluid or this little blood boil or blister to form. Okay, and then the reaction with the T cells, okay, that come in and they start to destroy and cause destruction of the skin cells if it's on the skin surface. Okay, so that was contact dermatitis. And it said lipid-soluble catechol are absorbed by the skin. That's your antigen. Dendritic cells close epithelium, pick up the allergen. They process it and display it on their MHC receptors. The previously sensitized T cells, which have the CD4, recognize the allergen. Okay, these helper cells are T helpers are activated, secrete their cytokines. Okay, the cytokines attract macrophages and cytotoxic T cells. The macrophages release their mediators that stimulate a strong local inflammatory reaction. Cytotoxic T cells directly kill the cells and damage the skin. And you get those fluid-filled blisters like boils. That's what contact dermatitis looks like. Okay. You get host rejection of a graft. So the host T cells release interleukin-2. That gives you more helper T cells and cytotoxic T cells, specific for the donor antigens. So you're killing it because it's recognizing the antigen in the donor site. Okay. The cells release lymphokines that begin the rejection of an organ or what else was transplanted. Graft rejection, okay. Any host tissue bearing MHC4 to the graft is attacked. Anything recognized as an allergen that's foreign to what is recognized as non-self is going to be attacked and destroyed. Okay. Again, the cytotoxic T cells start to destroy it, and they start to destroy the heart graft or whatever graft was put in, if they find it as organ. Same with the bone cells. They'll start to destroy the host bone cells. There's different types of grafts we can use. Okay? We can use an autograft, where the recipient also serves as a donor. We take it from a different site. Okay? We do grafts in the roof of the mouth or periodontal disease. We can take it from the palate and put the graft onto the outside of the teeth to help prevent periodontal disease from the breakdown of it. That's an autograft. Isograft, identical twin. Those are usually really good ways to do it. Allograft, genetically different individual, but it's the same species. It's human to human. Or xenograft. Xenograft is different species. Baboon hearts have been used to transplant for heart transplants for temporary use and so on. So you got autograft, which is the same person. Isograft, which is an identical twin. Allograft, which is a person genetically different, but it's still the same species. And a xenograft is different species altogether. Rejection can be minimized by doing tissue matching, which we try to do, and prevent the antigens from being identified as non-self. So we do tissue typing and we do a mixed lymphocyte reaction to try to minimize that. Yes.
These are for like implants? Like
for transplants.
Transplants. Oh, okay. Like kidney transplants.
Yes, heart, liver, lungs.
Oh, okay. All right. Thank you.
Oh, no problem. So what kind of antibodies would a patient with type B blood produce? Okay, so it's type B blood. You got the B receptors out here.
So anti-A antibodies?
Anti-A, so it would produce anti-antibodies. Would it also produce anti-B antibodies?
It would anti-B negative, right?
Yeah, it would not produce anti-B antibodies. Would produce anti-RH antibodies or anti-RH. Oh, anti-B. It had to be anti-A. So it'd have to be either A
or D.
C or D. Would it produce anti-An? Because this is B positive, so RH positive. So would RH positive have the antibodies to kill RH?
No,
you're right. Because it's already in the system, RH is there. You recognize it as foreign. So it would only be A would be the correct answer. It would not produce RH antibodies because it's RH. The person is type B and they're positive, RH positive. So it has the RH and an allergen on the cell. So there's no antibodies to it or that would destroy it. So it can only be A. Does that make sense?
Yes.
You can only have anti-A antibodies. Autoimmunity. So in certain types of type 2 and type 3 hypersensitivities, the immune system has lost its tolerance to autoantigens. It means it doesn't distinguish autoantigens as self. It forms autoantibodies, sensitized T cells against them. So in these types of diseases, where the immune system has lost its ability, which happens with age, genetic conditions, different diseases caused it like AIDS, things like that. Okay, the body finds these antigens and starts to recognize them as foreign, even though they're self. So disruption of function can be systemic. So it can affect the whole body, like AIDS does, or it can affect a certain specific organ, like rheumatoid arthritis affects your joints. Okay, so systemic lupus, like you talked about, can affect it. Rheumatoid arthritis, endocrine autoimmunities, myasthenia gravis, and multiple sclerosis are all diseases where the body is starting to recognize itself as foreign. The susceptibility is determined by genetics and influenced by the gender, male or female, and environmental factors. Okay, so it's the sequestered antigen theory. So during embryonic growth, some tissues are immunologically privileged. Yet forbidden clones, some clones which are not subject to the tolerance process, and they attack tissues carrying specific molecules. Sometimes the immune system just makes a mistake when it's developing and doesn't find the antigens that it's supposed to see and recognize and record it as self. So theories of immune deficiency, mutations in the receptor genes, okay, can cause some lymphocytes to run themselves reactive to self tissues. You get a mutation and it causes a gene to be produced that all of a sudden does not produce the right receptors. And now we find that as foreign. T cell regulatory cells, right, normally maintain tolerance to self have become dysfunctional. These mark things as regulatory and self, so we don't attack it. Molecular mimicry. Okay? Some microbial antigens are similar to normal human cells. Microbial infection systemic antibodies that can cross-react. So if we get an infection, our body responds to it. We make antibodies. The allergen on that microbe or bacteria is very, very similar to ones that are ourself. And so it starts to bind to ones that are close to it. And we get a cross-reaction. Of all the moons are shaped there, some of that's going to happen. And that's called molecular mimicry.
So molecular mimicry, so it's pretty much, it's so similar that it can't distinguish self from non-self.
Right. It's so similar that the antibody binds to both the pathogen and to the human cell. They're so similar in shape. And you get some cross-reaction to it. Which we think about because there's millions of shapes out there.
That's crazy.
Yeah. It's amazing how the different variations you can have. So here's your autoimmune disease and what they affect. Lupus is a systemic disease throughout the body. Okay, many organs, antibodies against red and white blood cells, platelets, clotting factors, nucleus, and DNA. Rheumatoid arthritis and ankylosing spondylolisthesis, okay, is systemic. Scleroderma is systemic. Hashimoto's disease. Hashimoto's disease is your thyroid disease. It's strictly related to the thyroid. It doesn't attack anything else and destroys thyroid particles. Graves' disease is also specific to your thyroid. Okay, and the antibodies against thyroid stimulating hormone receptors, and it bonds to that. Pernicious anemia is in your stomach. That affects your absorption of vitamin B12. Now, a lot of physicians miss this one, and they give patients vitamin B injections. Vitamin B injections aren't doing any good because it's the antibodies that are breaking down the vitamin B12 receptors, preventing it from going into the body. So you get vitamin D all day long, but it's not going to go into the body because receptors are damaged. And that's pernicious anemia. Okay. Myasthenia gravis. Okay. This targets your muscles. Targets the different myelination of the muscles, of the ACH receptors, of the neuromuscular junction. So the nerve can't transmit the information. Type 1 diabetes is the pancreas. It attacks. Multiple sclerosis attacks the myelin. Remember, myelin coats your nerve. You have your nerve that travels. This impulse travels down along the nerves. If it's myelinated, the impulse jumps from node to node. Okay, that allows a much faster, 100,000 times faster transmission with myelin than unmyelinated. So multiple sclerosis breaks down the myelin, resulting in loss of muscle control. Okay. Goodpasture syndrome. I had never heard of that. I had to look it up. Never heard it called Goodpasture syndrome. Glomerulonephritis is an inflammation in the kidneys. I never heard it called Goodpasture syndrome. Okay, that affects the kidneys. Rheumatic fever is your heart. Okay, antibodies, streptococcus react with the heart valve tissues and destroy the heart valve, causing a murmur in the heart. So lupus, okay, all patients produce autoantibodies against a variety of organs and tissues. Facial rash, you get that butterfly lesion on your face. One of the signs of lupus is the facial rash. Skin lesions, it also affects your kidneys, bone marrow, nervous system, joints, muscles, heart, and GI tract. It affects everything. Rheumatoid arthritis, okay, it's progressive debilitating damage to your joints. And this is that inflammation we talked about where it gets into the joints there and it causes that histamine release and prostaglandins and the destruction of that bone tissue. Okay. Now, the rheumatoid arthritis can occur in your lungs, your eyes, your skin, nervous system. All that can be affected by it. Okay. You've got rheumatoid arthritis, you can see everything's being destroyed and your joints are bending. Here's the butterfly lesion you get with lupus. Graves' disease, okay, receptor follicle cells secrete thyroxine, okay? So it increases levels of the hormone and it's hyperthyroidism, produces an overabundance of thyroxine, which results in increases in T3 and T4. Hashimoto's disease, okay, both autoantibodies and T cells are thyroid gland and reduce the levels of thyroxine. So it's hypothyroidism. So Graves' disease is hyperthyroidism. Hashimoto's disease is hypothyroidism. Okay, both are autoimmune diseases. Type 1 diabetes mellitus, the antibodies are sensitized to cell damage in the pancreas. They damage the beta cells in the pancreas that produce insulin. So it results in a reduction in insulin production. So even though diabetics eat it, they don't get the breakdown of the food. It doesn't get absorbed into the cells because you're not breaking down with the use of insulin to get the sugar out of the bloodstream. And this could pop into like the molecular mimic we talked about, where they're responding to another one that's similar to the cell receptors in the pancreas. So the body's responding to that as foreign. Myasthenia gravis is the automatic binding receptors for acetylcholine. Remember, the nerve comes down here at the end of the nerve, and then the next to propagate into the nerve or to the muscle to contract. Okay, it releases acetylcholine across this barrier. Okay, it binds to the receptors for acetylcholine. So basically, this releases the ACH in the joint to cause muscle to contract. But these receptors that recognize it are blocked. The antigen or they sit on that nerve and block that receptor. So the nerve can't transmit to the muscle can't contract. Even though the body's telling it to, it's releasing everything, the muscle can't contract. So you get very pronounced muscle weakness, complete loss of muscle function, and death. You gotta remember the heart's a muscle. The lung tissue is contracted by the diaphragm muscle. If you lose control of those muscles, it's not gonna be a good situation. Okay, so myasthenia gravis, this is what we have with a lot of vaccines that were not. The flu vaccine, the bird flu vaccine that was out. Myasthenia gravis was one of the side effects that we had of it. Okay. Multiple sclerosis, the myelin sheath is damaged. Both T cells and autoantibodies. We're talking about that myelin sheath that coats the nerve fibers that makes the nerve travel at super fast speeds. So we can react to things, so we can use it. If that myelin breaks down, that effect is lost. So we get it's a paralyzing neuromuscular disease because you can't transmit that signal fast enough to get to the muscle to move. So you get muscular weakness, you get tremors, the muscles start to shake, difficulty of speech, use your tongue and your lips. Okay, some of your paralysis, antigen triggered attack, still what the antigen is that triggers this is still unidentified for multiple sclerosis. So components of the immune system, okay? This is a deficiency, autoimmune deficiency, where components of the immune system are absent. So deficiency can involve B or T cells or both. It can involve the phagocytes that destroy the body, and it can involve the complement system where it's a progressive cascade going down. So the dysfunctional immunities can be grouped into primary diseases and secondary diseases. Primary diseases are congenital, genetic errors, mutations in the DNA passed on to the offspring, and you get the disease. It's congenital, you're born with it. Secondary diseases are acquired after birth, caused by natural or artificial agents in your environment. So primary is congenital, secondary is after birth. Okay. So primary immune deficiencies. B cell defects, low levels of B cells and antibodies. Get low levels of B cells, you get low levels of antibodies because they're not going to produce the antibodies. Those are X-linked, so they're not sex-linked because both males and females have the X chromosome. So you get A-gamma agglobulin, hypogamma agglobulin, selective immunoglobulin deficiencies, or you get T cell defects. Okay. Lack of all classes of T cells. Again, thymic aplasia or chronic mucocutaneous candidiasis. So B or C type. Okay, or you get a combined B and T cell defects. Okay. The different types of syndromes there, or you get the phagocyte defects. Okay. Celiac hydroxy syndrome, chronic granulocytic tissues of children, or lack of surface adhesion in molecules, where the phagocytes don't develop. So you can't destroy or engulf the different allergens. Or you get complement defects where it affects that cascading chain of events that occur. Lack of one of the C components, hereditary angioedema, okay, associated with the rheumatoid disease, the rheumatoid arthritis. Okay. This is like bubble boy. We get these autoimmune diseases where they can't come in contact with any allergens, or you get severe infection where the immune system just doesn't work. So some types of combined deficiencies, this is your stem cell. Then we can break into B cells and T cells. Okay, DeGeorge syndrome stops it right here before it gets to the thymus, so you don't have T cells. Okay. Congenital agammaglobulinemia prevent the B cells from maturing in the bone marrow. And the other diseases here, they stop the process at different areas, resulting in either lack of B cells or lack of T cells. That's your primary immunodeficiency. Those are your congenital. Secondary ones, okay? These are from natural causes. These are acquired. They're from the environment, okay? Infections like AIDS, leprosy, tuberculosis, measles, cancers, diabetes, nutritional deficiency, stress, pregnancy can cause that, or aging. Aging causes a lot of diseases. They just break down. They don't last forever. Immunosuppressive agents, radiation, where you're under radiation treatment to kill certain tissues. You can kill off other parts of your immune system also. Severe burns, steroids, okay? Drugs to treat graft rejections and cancer, removal of the spleen, which you talked about before. You know, that's our largest lymphatic organ in the body. Okay. So the immune system in cancer, it's a new growth of abnormal cells. Okay. So tumors can be benign, which means the cells are growing at a rapid rate. They're forming a tumor, but they're not spreading to different parts of the body. It's self-contained. That's benign. Or it could be malignant, where this tumor grows from these rapid cell rate, and then it starts to migrate to different parts of the body. When we see a tumor on X-rays, we see a mass in the jawbone, the first thing I check for is breast cancer, because one of the primary sites for migration from tumors in the jawbone is to the breasts. Okay? So that's malignant. It can spread to different organs, and different ones have propensities for different areas of the body. Okay? It appears to have genetic alterations. Could be radiation, could be any kind of any damage to DNA that disrupt the normal cell division. It disrupts mitosis. So it starts to divide uncontrolled. Possible causes can include errors in mitosis, genetic damage, activations of oncogenes in the DNA, or retroviruses like the AIDS virus. Okay, we have certain things that surveillance system. We talked about the natural killer cells. A lot of this function is the spleen. The immune system keeps cancer in check by detecting and eliminating cancer cells. And these are these NK cells, cytotoxic T cells and natural killer cells, and macrophages that dissolve, that break down into cells. But these NK cells go through the body and they look for cancerous cells, look for cells that are abnormal. So what autoimmune disease results in damage to the acetylcholine, ACH receptors, and blocks the nerve signal to muscle fibers? Which one was it?
I think it's multiple sclerosis. Or I think so. Muscle fibers?
Yeah, I think it's multiple sclerosis. No, myasthenia gravis.
Oh, no.
I was trying to remember too. Multiple sclerosis is the myelin.
Oh, okay. I was thinking.
Destroys the myelin. Myasthenia gravis was your ACH receptors. I couldn't remember either. I was having a hard time thinking. I know it was one of those two, because this is your thyroid and this is a systemic disease of lupus, which affects everything. But the multiple sclerosis affects your myelin development, and myasthenia gravis affects the ACH receptors.